somewhat reassured that stuff still bothers me, because the day it doesn't bother me is the day I need to go work at McDonald's or Walmart or someplace like that. But I appreciate the fact that things bother me, that, that we're exposed to human suffering. I mean, I always say we see patients on what they describe as one of the worst days of their life. We see people at the worst time in their life, and we witness firsthand the decline of society. I mean, we just see all of that stuff.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here, and welcome back to the Art of Emergency Nursing. My guest today has been one of the most frequently requested interviews I've had since I started the podcast. When I finally did get to interview him, he didn't disappoint. My guest today is a nurse educator, a humorist, and has been on TV multiple times on the show Untold Stories of the ER. You guessed it, my guest today is none other than the one, the only, Terry Foster. Enjoy the podcast.
Well, my name's Terry Foster. I'm a registered nurse. I have been a nurse since 1977. It's when I graduated from nursing school. So I have been an emergency room nurse that entire time. So it's 42 years. And my current position is I'm a clinical nurse specialist for the emergency departments at St. Elizabeth Healthcare, which is in northern part of Kentucky, and kind of have the best of all worlds with those ERs. We have a large, 600-bed hospital tertiary care facility, which is our mothership, and then we have two community hospitals, which are about 120 beds each in the suburbs. And then we have a freestanding emergency department that's kind of inner city, which was actually where our hospital was about 40 years ago. And then we also have a critical access hospital and emergency department in a rural area of Kentucky called Williamstown, Kentucky. So I kind of have like 5 completely different ERs, but 5 very similar ERs. So that's my position. But I also have a dual role at the hospital where I'm an ambassador for the St. Elizabeth Foundation, and what I do there is help with part-time with some fundraising, especially employee contributions and things like that for the hospital foundation.
That's cool.
It is, actually.
What are the differences? So you mentioned freestanding ERs, that you look after those in addition to your regular ER. What are the challenges unique to the freestanding ERs?
Well, for our freestanding ER, it's very inner city. It can be kind of a guttural place to work, and it's not for everybody. And there's some things that go on there that don't go on in our other emergency departments on a regular basis. We always get the shootings, the stabbings, the drug overdoses at different facilities periodically, but this one has a little more of a tendency because it's freestanding. It's kind of like you and the patient and God, and it's, you don't have, a full code blue team throughout the hospital and in-house physicians all over the place and nursing supervisors and everything. We tend, as a freestanding emergency department, tend to have our core staffing of an ER physician, nurse practitioner, the nurses, respiratory therapy, a clerk or a tech. And then, if you get an influx of patients, you just have to kind of handle them. We have some backup as far as, lab, x-ray, CT, things like that, but a lot of times that is the kind of the core bare minimum that they have in that department, and then we don't admit patients there, so you have to facilitate their transfer either to one of the inpatient hospitals or to a trauma center or one of our pediatric hospitals. So we kind of have to kind of juggle that just a little bit.
That's probably a little bit of a challenge for the nurses especially if they're used to the bigger hospital system where they got lots of friends, lots of resources.
Yes.
It's a big challenge going to a freestanding that's got very minimal.
It's minimum, and you have to know how to do a lot of different things. I mean, you may not have a maintenance person right there that can take care of something, or a housekeeping person, or food, or just kind of little things like that. And those are just things, and definitely like pharmacy. So a lot of times that's what you just have to pull those resources and figure out what it is you need to do.
Yeah, absolutely. So what made you decide to get into nursing?
Well, that's a good question. I mean, it's kind of the old reliable thing about I wanted to help people, and I still feel that way. But I think a lot of nurses go into nursing for that reason, but I never gave nursing a thought. And when I was in high school, my mother worked nights at the hospital and as an admitting clerk, and I kind of remember her conversation of when I was going to be off school that summer, something starting out with, "You're not going to lay around and do nothing all summer. I want you to do something." And she mentioned that they had this like volunteer program at the hospital, and so I went and took a little Red Cross first aid class and got my patch. So I was big time with that patch, and got a little volunteer jacket. And when I went to the floor they assigned me to, they said, "We're going to have this guy orient you." And it was a guy who was a nurse. And I had never had any idea. Of course, this was 1973. I had never had a clue that a guy was a nurse at all. I thought about becoming a physician, and I didn't think I was smart enough, which obviously that's kind of changed through the years, but that's another story. But
Yeah.
and then also I was from a large family, so I didn't know about like college costs and things like that. So anyway, when I was oriented by this nurse, I saw what he did, and I remember, I mean, I was very young then, but I picked up on the fact that he really talked to the families and the patients and had time with them, and could convey information about the patients to the doctor or the other nurses. And then I saw other nurses sort of in action, if there was something going on with the patient, and how they moved and how they picked up on things. And that really kind of appealed to me, and I thought, I think this is something that I want to do. So when I was graduating from high school, I applied to the hospital to be actually what was called a ward clerk, because I'd been a volunteer there. So they hired me as what was called a ward clerk then. And that way I got some really good firsthand experience besides being a volunteer into how the hospital functioned. When I was a volunteer, my mother worked at night, as I said, and so I got special dispensation or something to volunteer at night. And they said, "We've never had a volunteer here, and what if you fall asleep or things like that?" And I was like, "I don't think so." So they put me in the emergency room, which is kind of quite a place to put a 14-year-old kid
Holy
who's
cow.
a volunteer at night in an emergency room. But I loved it. I really knew, like after, I don't know, a couple of shifts that I was volunteering, I knew like I was home, that I felt comfortable, and I knew I was like, this is pretty cool. I like this here. And that's really was my kind of first introduction into the ER. Even though as I was a ward clerk, I was a ward clerk in the ER and on the floors, but I knew my love was for the emergency room. And again, in the ER, I really liked seeing how the nurses worked, and they just were moving patients and picking up on things and diagnosing and starting IVs and traumas and stuff like that. And I was like, I really like this. I think I'm going to go to nursing school. And I decided to apply to nursing school.
14 years old, they had you in the emergency department.
I didn't apply when I was 14.
No,
but
at 14 years old, they had you in the ER as a volunteer.
Yes. And
That's
actually,
crazy.
I can tell you, Kevin, I can remember working one night, and there was a family. This was probably 1974, 75. There was a family that was on their way back from a vacation somewhere. And this was before, flight, air transportation and trauma centers and stuff. And
Yeah.
there was, I think it was a head-on crash on the interstate, and there was this family of like 8 or 9 people that were just in this terrible accident, and they brought them all to our hospital. And at night there was one doctor, 2 RNs, and then sometimes maybe an orderly and me, and they brought all these patients in. And I can remember, like, I was like 14 or 15. I was holding traction, I was holding, pressure on lacerations. I mean, stuff that, like, there was just, they didn't really call it a disaster, but they called nurses down from other floors and stuff like that. But the initial part, we had all of that going on. And I remember seeing that. And like today, that would never happen, but that's just kind of trial by fire or whatever. And, and a couple of those patients died. And I remember one of them was a child. And, I saw all that firsthand and stuff.
Holy cow.
So, yeah.
How do you process something like that at 14? I can't even imagine. I mean, we had a volunteer in the emergency department that I had that was, she was like maybe 16, and we were like afraid she wasn't going to process.
Yep. And I guess back then, I'll be honest with you, no one asked me how I processed.
You just did.
It was just like, get over it, because I actually can remember, and this is another story, but when I applied to go to LPN school first, and but a lot of people don't know this, but I applied to go to LPN school and I was rejected. And I still have that letter somewhere where they said they didn't feel like, and it wasn't mean, but they said they didn't feel like I had what it took to be a nurse, and that my cumulative records were not supportive at this time. I can remember that phrase, like, what the heck does that mean? But I do remember thinking, like, they just know a snapshot of me. They don't know how much I care about patients, families, what I want to learn, how committed I would be, things like that. And I'm not vengeful, like people are like, oh, you should, send them that letter now. Where I can tell you, those people that sent me that letter are probably all dead now. So not like that. But I just remember thinking, like, I know better. Like, I knew it was going to be okay, but that was very much a letdown to me. And so I started in an LPN school, and it was a hospital-based school. It was Booth Memorial Hospital School of Practical Nursing in Covington, Kentucky, which has long been closed now. But I went there, and they were really, really focused on clinical. I had a lot of clinical on my LPN experience. We worked the wards, we worked OB, PD, emergency room, surgery, intensive care. We did, as an LPN, we did all that. But we just hit the ground running. But and I also remind people, or like to tell people, my tuition for that full year of LPN school was $425, and my parents told me, if you pay half, we'll pay the other half, which was just great. And I saved up the money to pay that. And then my parents told me, because I worked on weekends as a ward clerk, my parents said, you can, you're here at the house, you're 19 years old, you don't have to pay room and board, live here for free. But if you're not working or going to school, it was from a large family, my brothers had to pay room and board after they graduated from high school. But what I was going to tell you, and about 3 months before I graduated, or 2 months, there was a Beverly Hills Supper Club fire, which was in Southgate, Kentucky, which happened on May 28, 1977. And I ran on our local life squad in Taylor Mill, Kentucky. And and it was a terrible disaster. Actually, 189 people died in this fire,
Holy cow.
and about probably I think like there was hundreds of people that were injured. And so I went to the site. I went up to the firehouse, and the ambulance had already left. They called every ambulance in northern Kentucky and greater Cincinnati. Again, this was 1977. There was no helicopter service, trauma centers, anything like that. So I drove to where the fire was and parked a ways away and climbed up this hill. I mean, I had no uniform on that I can remember. Maybe I don't know, but as I got up to the top of the hill, I could see these people to the right of me. I mean, the building's on fire. There's people all over the place, but there were people like laying on the ground, and I thought, what what are they doing? Like, why are those people laying there? It was about 10 people laying there. I thought that's the dumbest thing in the world. Are they waiting to go to the hospital or what? And keep in mind I was 19 years old. And then I looked and I realized they were all dead and they weren't burned. They had all had smoke inhalation. And I can remember like an older lady was slightly propped up and she had these earrings that hung down and they were kind of moving with the wind a little bit, and she had a corsage on, like when ladies wore corsages, and it was kind of wilted a little bit, I guess, from the heat and stuff. And I thought, oh my gosh, this fire's killed like 10 people. It took a while when you talk about processing to process that. And then they said there was like a medical place in the back to go back there. And I went around the building. And then when I got in the back, there were probably, I would say, probably 100 people laying in this courtyard area that were all dead. And it was just something it just it was overwhelming. And today I guess you'd be in therapy for it, or some kind of debriefing, which is fine, or EAP referral, whatever. But it was just like you just saw them, and it's something I'm not proud of, but I've never seen that many dead people ever again,
Wow.
as I did then. And there was it disturbed me because disaster medicine is completely different, and disaster triage is completely different from what we know as triage. But when the women, a lot of women, wore long dresses and stuff then, and when they pronounced the women dead, they pulled their dress up over their head, like, and so these ladies were laying there. I mean, they had like their pantyhose on or underwear or whatever, but you couldn't see who they were. But that still disturbed me. But that's how they had to mark them, that they were dead and
Wow.
stuff. And so, and the men, they put their sport coat over their head, so that meant they were pronounced. So, like sometimes when I think about processing stuff, I think, that, and we went to the hospital. They said go to the hospital, and we were students, and we took care of tons of patients, with burns and a ton of smoke inhalation. Like when they used to do Bennett treatments and things like that for patients, and they just had this soot and stuff like that. We just took care of, as students, we just took care of all those patients. So anyway, that was a mouthful when you said, how do you process that? I know.
Well, it and it's crazy because you think, you talk about PTSD, and most ER nurses that I know see more death and destruction and terrible things than most people.
Yes.
And there seems to be a difference, and I don't know what it is. There seems to be a difference between those who process that well and do okay and are okay, and those that don't. I mean, I don't know how many nurses I know that are heavy drinkers, or that
Yeah.
have gotten themselves into trouble with other stuff.
Right.
And you're like,
I agree.
what do you think makes the difference between those who can cope and deal with that and be okay, and those that don't? Like, what do you think makes that difference?
I honestly believe it depends on a lot of a person's personality and makeup. Like how resilient are you? What kind of faith based beliefs do you have, or and I'm not saying, like, I'm not talking a religion, but just, what do you believe is true, and how do you, like, get through those things, and what do you call upon? And I think it's a combination of things. And there's sometimes, where it's like, my coworkers help me through it. Sometimes my faith does. And then there's other times where I just talk it out in my head. And then there's other times where I can't get through it, where it's like it's on my mind, it's bothering me, I'm dreaming about this patient, or all nurses have, like, had a terrible shift and then went home and slept and worked another shift in their sleep, and
Yep.
thinking
Amen.
about the IVs beeping and what did they chart and things like that. And so there's a lot of that. But I am somewhat reassured that stuff still bothers me, because the day it doesn't bother me is the day I need to go work at McDonald's or Walmart or someplace like that. But I appreciate the fact that things bother me, that that we're exposed to human suffering. I mean, I always say we see patients on what they describe as one of the worst days of their life. We see people at the worst time in their life, and we witness firsthand the decline of society. I mean, we just see all of that stuff, and you have to process it and get through it. And then one of the things I always believe in is, obviously the use of humor, when it's appropriate. Sometimes that's how we get through it. And even when it's almost not appropriate, we kind of think, I can't believe, we're getting through this with humor, but I don't know another way to do it at the time.
Yeah.
And that works for me, but nothing works the same all the time.
Yeah, no, I agree. I agree for sure. I tend to use a little bit of humor too, and just kind of lighten things up, and
Sure.
A lot of times it helps. And you
Yep.
can't do it with everybody, and you usually pretty much gauge who you can and who you can't. But
Right.
I've been wrong before, but not very
Yep.
often. Do you remember ever having the death talk? The first time you had the death talk with a family, when you had to let them know that either somebody hadn't made it or was likely not to make it?
Yes. I remember that, and I have to say it was always something that I felt really pretty comfortable with doing, because I can remember one time we had a kid that was hit by a car that he when he came in, he acted like a skull fracture. I mean, it's like a 5-year-old kid laying perfectly still on the stretcher. It's like, he's got something going on, and this kid started to seize. And I was like, this other nurse, I said, I'm gonna talk to the family and let them know and see what's going on. And this other nurse, he said, no, you can't do that. The doctor needs to talk to the family. And the family came back, and the doctor says, like, yells. I mean, this was years and years ago. Kind of yells about 3 stretchers over. Yeah, it's not looking good. He's going to Children's. And then, like, somebody took him back outside, and it was like, oh, for God's sakes, I could have done a hell of a lot better job than that,
Yeah.
And the doctor didn't mean it mean. He was worried about the kid and that kind of stuff. So I've always felt like I've had just a way to connect with them, like, hey, this is the way it is. It doesn't look good. I want to let you know what we're doing. What do you want? Do you want to be back there? Those kind of things, keeping them appraised. And I've always felt comfortable in that role. And I always try to, I don't mean like I'm the big expert, but I try to get a new nurse. I'll just say, come out here with me, and we'll try to kind of do this together and stuff. And I mean, I can tell you, I'm at work right now, and if something happened later on, I was talking to the family, I can still get choked up, telling them, especially if it's a relatable situation.
Absolutely. I think that all of us can very easily have that conversation. I had a situation not that long ago where I was talking to, I just come on shift, and there's code blue, and I go up to the code, and this woman's there, and the wife goes, the doctor told me that he was going to be okay. And I'm like looking at him going, okay, from what I know in the situation right now, he is not okay.
Right, right.
And I told her just like that. I said, haven't looked at the chart. I'm about 5 minutes into this. I go, but what I can tell you is he's not okay. He's fighting for his life. And I go, and if we didn't make that clear to you, then shame on us.
Right.
Because he's fighting for his life. And I go, and I just want to make sure that's what you want. And she's like, that's what I want. And I go, then fight we shall. And,
Good.
And it was tough conversation, and ended up, being over the next 3 days. I got to deal with this family, and it was amazing. I say deal with them, and I work with them, and it was amazing. But ultimately, then you get to have the talk of, okay, now it's time to maybe talk about withdrawing care.
Right.
So, wow. Boy, I certainly didn't expect that our conversation would get this heavy, my friend.
I guess I'm sounding like a Dr. Phil show here, huh?
I love it. I love it. Well, we'll lighten it up a little bit. Tell me about a patient who made you laugh and that you'll never forget.
Oh my gosh. I mean, a ton. Like, I do a lot of nursing humor kind of things, and they're all stories that are funny stories that every nurse I know has said, you can't make this stuff up. Every nurse, not just ER nurse, every nurse I know has said we could write a book. And so, some of the stuff that patients say and do, it's hysterical. And I'm not laughing at them. I'm laughing at the situation of what people say and do, and I try to not to put my values on somebody else, but like some of the stuff that people come up with, it's just amazing to me what people do sometimes when they're in pain, when they're drunk, when they're high, when they're just like kind of being a good old boy or a good old girl or whatever it is, and have some liquid encouragement, things like that. Those kind of things just crack me up. What I love is just how human beings are in whatever environment that they come from. And what I like about my job is the enjoyment and the fun I get to take care of people from every walk of life, every skin color, every ethnicity, every dialect, every accent, every cultural background, every educational background, and every level in society. I mean, to me, that's just I'm never tired of that at all. But I do have to say I enjoy my patients that are just what you see is what you get, and they crack me up when they're, if they've been drinking and some of the stuff that they say or do and stuff. That is funny to me. Like people will say to me sometime when I do these humor talks and things like that, they'll say, "Where do you get your material?" And I say, "I clock in." Like this is not, none of this is scripted. How I tell it's storytelling or scripting a little bit in my head, not on paper, but it's just I clock in. It's handed to me on a silver platter. I had a patient not too long ago, a little elderly man, and I was checking him in, doing the med reconciliation with him, and I was asking about this one medicine. I said, "What about this one medicine?" He said, "I don't take that anymore." And I said, "How come?" He said, "It don't work. I think it's one of them gazebos." And I said, "What do you mean?" He goes, "It's a gazebo. You don't know what the hell you're getting. It's a sugar pill." And I was like, "Okay, that's a gazebo." He obviously meant a placebo, but it's just stuff like that that is just like, thank you God for giving me this information. This is what I needed. It was a little stressful. We had a young girl. I've told this story several times. Young girl that came in, and she needed to go up to surgery for an appendectomy, and the nurse went in the room to do her pre-op checklist and get her clothes off and her jewelry and that kind of stuff. And the clerk went in and put an N.P.O sign above the bed and walked out. And the patient goes, "You got to put that sign right above there." And the nurse goes, "Yeah, that's so people know." And the patient said, "I don't want everybody looking at that sign that comes in." And the nurse said, "It's okay. What's wrong?" And she said, "Well, everybody that walks in here will know I have no panties on." That's what she thought N.P.O stood for. But the nurse said she noticed, she had her covered up, but she was slipping her panties off. And the clerk put the N.P.O sign above the bed. And I guess that girl just thought, man, they don't miss anything around here, And it was the N.P.O sign. So it's just those kind of experiences. It's just like that. It just cracks you up. And I don't laugh in front of patients, but sometimes patients will start laughing themselves and bring something up like that. I'm like, that's okay. I go, we'll just laugh here together. And then there's more guttural things and more personal and kind of sexual things that people say and do, and it's just like, oh my gosh, you can't make it up, and it is funny stuff. I don't care what anybody says. It can be very funny.
Absolutely. What's the best advice your mom gave you that you've taken onto your nursing career?
Oh my gosh. I would say her philosophy was just telling, like being true to yourself. Pardon me. Just more like my mother was a rather outspoken but very kind person. She didn't say things to people that were hurtful or anything like that, but she was from Kentucky, Southern, and kind of like, as they would say, spoke her mind or spoke her piece, however you want to say that, and just kind of being direct. And when you get older, it's easier to do. Like when I first started out, I could have never talked to a doctor like I think about how I talk to a doctor now. And I don't talk to a doctor mean or rudely or anything like that, but I'm much more of a patient advocate now, where years ago it took a lot to stand up to a doctor because I was younger and I was inexperienced, where I see now about, I have no problem saying, and not just to a doctor, I mean any kind of situation where I would say, hey, we're not treating this patient that way. We need to do this for them, or somebody needs to go in and check them, or we need to do this here. We need to do the right thing. I'm much more comfortable with that, and I do remember my mom and my dad, both of them, doing that.
That's good advice. Good advice, and it's different now. You think of the way you talk to doctors, and when you started your career, you'd never be like, "Hey, Bob, go see the patient in bed too."
Yeah.
You'd be like, yeah, like that would never happen.
I remember one time a patient was, I worked in ICU also, and a patient was not doing well, and they kept calling this doctor, who I guess was a resident, and he was in the house, but he wasn't responding. And finally, he came through the doors, and this nurse goes, "You need to get your ass in there and see that patient in room 4." And she goes, and this patient was not doing well. They were circling the drain for sure. And I remember thinking, I never knew a nurse could talk to a doctor like that. And I thought, I really like her, but I hope they don't fire her for talking to that doctor like that. And of course they didn't, because she was advocating for the patient and stuff. And I remember thinking, like, she was an older nurse, like she had more experience as a nurse. She had been a nurse longer than this resident had been alive, but I still thought, like, as far as the pecking order goes, she might get in trouble for that. So I would, again, I'm not rude to physicians or anybody, if any situation where a patient's not being treated right, I would definitely stand up for them and be their advocate.
Absolutely.
And happy to do it.
Absolutely. Now, tell me, what does it take to be a stellar nurse?
You want to ask somebody else, or you asking me? Huh?
Well, you certainly you've seen stellar nurses. If you haven't been one yourself, certainly you've seen some.
Well, you know what? That's funny you say that because I have no problem telling people I am a really good nurse. If you're having the big one, I'm your guy. If you're in a traumatic accident, if your child has a pediatric emergency, what if you're having a AAA that's ruptured or a kidney stone or whatever, I'm your guy. I will take really good care of you. And it took me a while to I wanted to be that way, and I feel very comfortable that way now. But I remember thinking when I became a nurse that even as a student and as an LPN, I went back to RN school, obviously, and I decided to go to a hospital-based diploma RN program. And a lot of nurses that I worked with said, you should go get your BSN, get your BSN. And I remember as an LPN, I noticed the best nurses that I worked with were nurses that graduated from diploma programs in my area who hit the ground running and could take care of a patient with no problem. And that's not a put down to an associate's degree or BSN nurse at all, but this was kind of back in the day. We had just in Cincinnati, we had Bethesda Christ Deaconess, Good Sam Jewish Hospital, Mercy Hospital, St. Elizabeth. We had several hospital diploma programs, which are gone now because they didn't give you any or very little college credit. And I certainly believe that nurses need that formal education, but those were the options then. And I wanted to go to a diploma program because that would give me the most clinical experience. And then I remember thinking when I graduated, I always wanted to take the sickest patient that I could because I would learn the most from them. And I did that. Anytime a trauma or a code or an MI or anything bad like that would come in, I would always try and take that patient because I felt like I would just really learn a lot. It'd be the biggest test of my skills and knowledge or whatever to learn that. And then I also remember that I very much early on wanted to get my certification in emergency nursing, and I studied for that very quickly. As a matter of fact, I graduated from RN school in 81 and I took the CEN exam in 82, but I'd been an LPN in the ER for 4 years when they had LPNs in the ER before that, and I took the exam and I passed it, and I felt like
Nice.
that was kind of the backing that I needed to say, yeah, this sort of proves that I do kind of know what I'm doing here. And
Yeah.
I didn't mean it in a bragging way, but I meant it more that okay, this is sort of validation, okay, I'm getting this pretty good here.
Absolutely. I did the same thing. I think I was an ER nurse for, I don't know, maybe 6 or 8 months before I took the CEN the first time.
Oh,
And
wow. Good for you.
and it was, but I was a ER tech for 10 years before that, and
Right.
an EMS instructor and a really good student. So it was an easy test. Yeah, not an easy test because it's not an easy test.
Right.
But it was a test that didn't scare me.
Sure. And you pick up on a lot of stuff, obviously, by all those things too.
And I was motivated because, I finished nursing school. I finished nursing school and I was working at the community college part time at the time, and I was making more as a community college instructor, as an EMS instructor. I was making more than I made as a nurse. And
Wow, that's
my
great.
and my boss told me, my boss was like, go get your, you got to get your career advancement points. And he's like, go get a national certification or a bachelor's degree and you'll get a raise. And I was like, well, I don't have time to get a bachelor's degree, but I'll go get that certification. So I had a $5 an hour motivation to go take that. So
That's good. That's pretty good.
and it's not bad. It's not bad. So yeah, I did the same thing. Now, emergency nursing, your career as a nurse has opened up a lot of doors for you. What kind of cool stuff did you get to do as a result of being a nurse?
Well, it's just been the best job I could have ever asked for. I mean, I think about the benefits that I've had and things like that. What I like about it, every day's different. I like the flexibility. I like the autonomy. I like the personal satisfaction. I like going and taking care of a sick person, and when they say, "Oh my gosh, I'm glad you were here," or "You made me feel better," or things like that, and that I like having a positive influence on people that, if you see them somewhere and they're like, "Oh, you took care of me. Thank you so much." I mean, that just that really helps me. I like that. And not all of it's always good and things like that, but also just through the years, I went back to school. I got my master's in critical care and trauma nursing when they had a program, pardon me, in at the University of Cincinnati College of Nursing. They don't have that program anymore, but I graduated from there in 1997, and would just loved that I could have that critical care trauma graduate degree. That really helped me. And then I did my certifications. I've been an ENA member almost from day one, but I started doing a lot of teaching, and it was kind of like a critical care instructor at the hospital. I started kind of doing that to help orient nurses to ICU and ER and the recovery room and things like that. And I would have to teach classes like not have to, but I did like blood gases and ACLS and shock and EKG, and I always kind of wanted to, make them entertaining and humorous. So I always tried to, throw in some humor and things like that. So my kind of lecturing, I guess, was locally at my hospital, and then I spoke for like my ENA and AACN chapter, and then if there'd be a conference here or there, I don't know if I would submit or maybe they asked me, or pardon me, a combination of both. And I started teaching in some state conferences, and then there was like a company or two where they had continuing education offerings, and I would teach like med surg emergencies. I used to teach that a lot. Summer emergencies, winter emergencies. Then I thought we're going to start doing bar mitzvah emergencies or something like that. I don't know, but just a lot of different ones. And actually, I've been able to, I've actually lectured in all 50 states, which I wanted to do that by the time I was 50, and I did. And I've taught classes in Canada, Mexico, on two continuing education cruises. I've been able to write and publish some articles in nursing journals and some textbooks and things like that. And then about 10 years ago, I was approached by the Learning Channel's Untold Stories of the ER, and they wanted to know if I wanted to film a segment on a unique story. And actually, the person who called me, I thought it was a joke. I thought my neighbor was playing a joke on me, and I'd never heard of the show before. And so I insisted that I had to call this lady back, and she was like, "Can you talk now?" And I'm like, "No, I got to call you back." And she gave me a number, and I was afraid to call it because I thought it'd be like a phone sex number or something, that I would really be set up for this joke, and I didn't want to have a phone sex line that I called from my office on the record here at the hospital.
Probably good practice. Yeah, probably pretty good idea.
Yeah, so I called the number from home, and it was all legit and stuff. So anyway, so I've been on Untold Stories of the ER. We just filmed our 10th episode for that in the spring, and that'll be on the early part of next year. And they're all my stories, but they're reenactments and stuff. And so the show actually, pardon me, has quite a following, which I had just no idea about and stuff. And sometimes I've gotten some very interesting emails and Facebook messages and things like that. Most all of them are very complimentary, which is very nice. But there's a few people that said that I was judgmental or whatever, and again, they're reenactments, and I'm not a judgmental person, but some of the things on YouTube, people will put comments, which you can anonymously comment anything you want. So I tend not to read those or whatever, because whether they're good or bad or something like that, it's okay. I'm comfortable with myself and what I've done for those, but again, they're reenactments and stuff, and they're all have like a unusual presentation, and then like a twist and a turn, and then a resolution, which, as you know, is not every ER case that you get. Some of them
Of
you
course
don't
not.
resolve. Some of them we lose the patient. Some of them we never find out what's going on. So it is TV. So but they've actually been really good about. I wanted to make sure that we didn't alter the program or the story just for TV purposes, and so they've been pretty good about that and stuff, sticking to what it really is and stuff. So
That's good. That's
yeah,
cool. What a cool opportunity to get to represent emergency nursing in
yes.
all our glory.
Well, and actually, when this producer called me, I was going to present in Seattle, and they were based in Vancouver, British Columbia, and they were going to come hear me talk. And so they came down to hear me talk. I did a presentation for ENA and ASEP on bizarre and spectacular cases in the ER, because that was like a hit on the internet or something on their search, and they saw my name. So they came to hear me do the talk, and when it was over, these are young ladies like in their mid 20s that were production assistants, I think, and they were like, you did a really good job, but we can't use you. And I said, oh, okay. You all contacted me, and I said, why can't you use me? And they said, well, you're a nurse. We thought you were a doctor. And I'm like, no, everything I have has RN written behind my name. And I said, well, why don't you use a nurse? And they said, well, doctors know more about what all's going on, and they kind of run the emergency room. And
Oh my
I
gosh.
said, well, I know. I said, that really isn't how it happens. And I said, let me tell you what I do. So as I went through a couple things saying what I did, they were like, and again, they had like production and media
Yeah.
backgrounds. They were
What do
like,
they know?
yeah, and they're like, we had no idea, and they said, we're going to pitch this idea. So I was actually the first nurse to be featured on the show. They were all doctors before that, so they've actually, I think, had two other nurses since me, but I was the first nurse. And there were a couple of things like some of the filming it's filmed out of sequence from how you watch it.
Yeah.
So I remember our first scene, the patient was going to be discharged, and in the first scene they had the doctor go in and get the patient dressed and get her in a wheelchair and wheel her out to the car. and of course I'm like, oh hell no. I'm like, that's not how it happens. And they, again, like I said, they want to make it as real as they possibly can. So I said, number one, I don't want my doctor taking a patient out to the parking lot. They need to be in here, but this isn't how we do it. So they were pretty good about my input and things like that. Or they would, like one time, the doctor in the script was going to say, for a trauma patient, Terry, start 2 large bore IV stat. And I said I would have those IVs in the patient as the doctor was seeing them. And they were like, oh, okay. So they've been pretty good as far as that goes. And I want to make it realistic, so.
That's cool. What a cool opportunity.
Yeah, it is. It's been a lot of fun.
I bet. The last question is a question I ask all my guests, and it's a doozy. It is a question called 3 things. And what I'm going to ask you for 3 things an ER nurse should always remember, and 3 things an ER nurse can just go ahead and forget.
Why didn't you give me these beforehand? Okay, that would have been a lot easier. Okay, okay.
You come up with 3 things off the top of your head for sure. Like,
okay,
there's some guests I worry about not being able to do this. You're not one of them. You're going to be fine.
Okay, what I would say first and foremost, always keep learning as an ER nurse. That's just something you always want to do that, and I do that every day. I either learn something about a drug, a procedure, a disease, or whatever. The second thing is I learned so much from my patients and or their families. Just because we have the medical background doesn't mean we're always the expert. And sometimes if you're kind of humble and willing to listen to a family or a mom or, a little lady who's been married to this guy for 62 years, she knows him better than anybody else. Listen to what she has to say, and that you can learn from them so much. So, and then also then the last one is, to me, always have a sense of humor, knowing when to turn it on and off, but a sense of humor to help you cope, to balance out with the things. And plus, everybody likes to have fun at work, and sometimes working in the ER ain't so much fun. I mean, you think of the workload stress and the the workplace violence and the addiction issues, and you're working weekends and holidays and
It's
nights.
sometimes a hard job.
Yeah, and we see some sad stuff. And I think having that sense of humor really kind of balances that kind of stuff out. Okay, the things that a nurse can forget. Okay, I still do not use algebra when I take care of patients. I still do not know or do not use the Krebs cycle in almost anything it is that I do. And then let me see, the third thing, okay, I would say nursing diagnosis or nursing care plans. Somehow I've been able to take care of patients pretty good for 42 years and not use nursing diagnosis and not use a nursing care plan on them. And my people in academia, my friends, would probably just be dying that I said that, but that's the truth.
That's
And
you're absolutely
you know what?
fair.
I forgot to add one. A really neat thing too is that about being on the Emergency Nurses Association Board of Directors. I just, started that in January, so I've been on that about 8 months. That's been a phenomenal experience. Learned a lot about our association management, ER nurses throughout the country and the world, and it's just been great. And I've got a little over 2 years more to serve on the board, and I'm really looking forward to it. It's just been a great experience.
What's been the coolest part of being on the board?
I would say having input on what the nurses in the emergency nurses in this country want, like knowing how concerned they are about things like workplace violence and the opioid epidemic, and obviously, being able to provide care to patients and having the balance of technical and, personal kind of work, and that they're able to do that and be supported by their employers and by their associations, which I feel like is a really big part of our job.
Absolutely. That's cool. Yeah, it's an awesome opportunity to be able to represent the community, truly be a representative of the community, and for not only the nation, but not only for in the country, but for the world.
I agree, and we have our first international board representative now, Hoop Brewer, which is great, and we're glad to have him. And it's really neat to kind of have that perspective and that input.
Yeah, he interviewed on the podcast not too long ago and was phenomenal.
So who do you think did better, he or I? And be sure and say it was me, okay? And tell him that, all right?
Okay, I'm going to leave that in.
Yeah, okay, please do. I love it.
So is there anything I should have asked you that I didn't?
No, I don't. I mean, I didn't really know exactly what you would ask me, and so no, I think you covered a lot, and I would just say, if anybody, I just think we're in this together. If some days you're like, I don't know if I can do this anymore or whatever, and I just think, we just need caring, competent nurses to stay in this profession, stay at the bedside, and anything I can do, to keep that a really good nurse at the bedside, I'm certainly going to do, because it's a rough calling, but you know what? I'm really glad that we've got people out there that are up to the challenge, and in my day, which I feel like I'm still in my day, but we know like a lot of nurses today who have been ER nurses 30, 35, and 40 years. I don't think you're going to see that ever again. Our tenure in the ER is maybe 3, 5, 7 years, and then people move on. And I don't know that that's a good or a bad thing. That's just the way it is. And a lot of them move on for advanced degrees or education or things like that, which I think is fine. But I don't think we're going to see that era again of people working in any area of nursing. That used to have surgery nurses, been there 45 years, ICU nurses, that long NICU, things like that. I don't think you're going to see that again. And that's just the way that it is for now.
Yep. Well, Terry, I can't thank you enough for taking the time to do this with me.
Well, thank you, Kevin. I appreciate it. I feel like I need an oxygen mask right now. I've talked your arm off.
It's a lot to cover. It's a lot to cover
in an hour. Especially when you've been doing it as long as I have. So I have no plans for retirement. I'm 61 years old, and I'm going to work another 10 years. I don't do patient care every day, so that makes a really big difference. So, but I plan on staying around for quite a while.
Good for you. Good for you.
Yeah. Thank you.
Well,
thank you, Kevin, very much.
I appreciate you taking the time to do it with me.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.